Hello everyone and welcome. In this video, we are going to cover important federal topics expected on your MPJE exam. So first, let's go over what to expect on the MPJE exam. You'll have 2.5 hours to complete the test, which consists of 120 questions. However, only 100 of those are scored. The remaining 20 are pre-test questions that won't count toward your score, but are mixed in to help evaluate future exam questions. Now, let's talk about the types of questions you might encounter on your exam. The first type of question is multiple choice, which have one correct answer among several options. Then there are multiple responses. Some questions will have more than one correct answer, and you must select all correct choices to get credit. And finally, there are K-type questions. These require picking a combination of answers, but they're being phased out, so you may not see many. The content is integrated, meaning federal and state-specific questions are mixed together. They won't be labeled separately. That means you'll need to apply both federal and state pharmacy laws relevant to your licensing. So when you take the MPJE, be prepared for a mix of question formats and make sure you have a solid understanding of both federal and state regulations. The materials we're covering today closely follow the book shown here, which is available on Amazon. One of the best ways to reinforce what you learn is through active engagement, and that's exactly what this book offers. It includes coloring images, which helps you integrate information into your long-term memory for easier recall, both during your exam and long afterward. That's why we recommend starting with this book. However, if you're short on time and need to focus on key content quickly, you might prefer the Federal MPJE Study Guide Pocket Booklet. It's a more condensed resource without coloring photos, designed to help you move through the material efficiently. We also offer state-specific books that go beyond federal content. These guides cover important state-specific topics such as the composition of the Board of Pharmacy, CME requirements for license renewal, and other regulations unique to each state. If you are taking the exam in any of these states, we highly recommend getting the corresponding book to ensure you're fully prepared. To make things easy, the QR code provided will take you directly to our Amazon page where you'll find all 6 books available for purchase. These books are offered at a fraction of the cost compared to similar resources elsewhere, and we appreciate your support and interest in our materials, and we're confident they'll help you succeed on your exam. All right, without further ado, let's jump right in and go over the key concepts you need to know for the exam. Just a quick note, laws and regulations are always evolving, so if there are any updates, we'll make sure to include them in the video description. Chapter 1, U.S. Healthcare Regulation. The U.S. healthcare system is regulated by various laws and agencies to protect public health, ensure drug safety, and maintain ethical standards. Federal laws set the rules for drug manufacturing, labeling, advertising, and distribution, which healthcare professionals must follow to ensure compliance and patient safety. Several federal agencies play a major role in regulating healthcare and pharmaceuticals. The FDA oversees drug approvals, safety, and manufacturing standards. Established in 1906, it enforces good manufacturing practices and ensures that drugs, medical devices, and cosmetics meet safety and quality standards. The FDA also provides color-coded reference books, which we'll review next. The CMS manages Medicare, Medicaid, and CHIP, setting rules for eligibility, coverage, and payments. Medicare Part D, which covers prescription drugs, requires CMS approval before making any changes to formularies. In long-term care facilities, LTCFs, CMS mandates that a pharmacist reviews residents' medications monthly and reports any irregularities to the appropriate medical staff. The CMS also requires tamper-resistant prescription pads for Medicaid outpatient drugs to help prevent fraud and unauthorized alterations. The FDA and other health organizations provide several color reference books, each serving a specific purpose. Let's go through some of the key ones. First, we have the Red Book. This one focuses on drug pricing. It helps healthcare professionals manage costs by providing up-to-date pricing information for medications. Next is the Orange Book officially called Approved Drug Products with Therapeutic Equivalence. This book is essential for identifying generic equivalents and understanding which drugs can be safely substituted. It assigns therapeutic equivalence TE codes, which have two parts. The first letter tells us if a drug is therapeutically equivalent to its brand name counterpart. The letter A means these drugs meet bioequivalence standards and are considered interchangeable. So the memory aid that I have for you is A standing for alternative. Then we can have the letter B. If it is listed as the first letter in Orange book, it means that these drugs have the same active components but don't meet full therapeutic equivalence standards. So the memory aid I have for this one is B, standing for basic ingredients. The second letter refers to the dosage form, and here's an easy way to remember them. B for bedrock solid dosage forms, and for nitrogen solutions or powders for inhalation. O for oil, injectable oil-based solutions. T for parenteral injectable aqueous solutions. T for topical solutions. R for rectal suppositories and enemas. Moving on, the yellow book is a must-have for international travelers. It provides guidance on vaccinations and health precautions for different regions of the world. The green book is geared toward veterinary medicine, listing approved animal drug products. The pink book is all about vaccines. It covers vaccine-preventable diseases and official vaccination guidelines, making it a key resource for immunization practices. And finally, the purple book is the go-to reference for biologics and biosimilars. It lists licensed biological products, including those that are interchangeable, helping healthcare providers navigate biologic therapies. Now, to make it easier to remember these reference books, we've got some images to help you visualize the key concepts. Think of oranges and tangerines. They taste almost the same, right? That's my way to remember the orange book, which helps identify generic equivalents of drugs. Think of a red alert when prices are high. That's your clue for the red book, which provides drug pricing information. Think pink for prevention. That's how you can remember the pink book, which focuses on vaccine preventable diseases and immunization guidelines. Think about how most cats have green eyes. That's your cue for the green book, which focuses on approved animal drug products in veterinary medicine. Think of the yellow pages used for finding travel agencies. That's your hint for the yellow book, which provides health guidelines for international travel. And finally, think about how gram-positive bacteria or biological agents stain purple in a gram stain. That's a great way to remember the purple book, which focuses on biological products and biosimilars. Moving on to Chapter 2, which covers key federal drug and health acts. Federal laws have played a major role in shaping drug safety, distribution, and healthcare services in the U.S. Over the years, several landmark acts have defined the pharmaceutical industry, setting critical safety standards to protect public health. In this chapter, we'll go over some of the most important federal laws, their historical background, and how they continue to impact both the industry and consumers today. So first we have the Pure Food and Drug Act, which was the first major law in the U.S. to regulate food and drugs. It was passed in response to public outrage over unsanitary practices in the food and pharmaceutical industries, which were exposed by journalists and social reformers. While this law wasn't perfect, it laid the foundation for future drug safety regulation. The act mainly targeted adulteration and misbranding of food and drugs. Adulteration means a product's composition is unsafe or impure. A drug is considered adulterated if it's contaminated or expired, stored or prepared in unsanitary conditions, made with unapproved additives, or harmful container materials, weaker, impure, or lower quality than official standards. On the other hand, we have misbranding, which refers to false or misleading labeling. A drug is misbranded if it lacks key information, like the manufacturer's name or drug ingredients. It doesn't say RX only for prescription drugs. It fails to provide clear warnings or directions for safe use. it's sold under the wrong drug name or without a valid prescription. Here's a memory aid to help you remember the difference between misbranded and adulterated. Take a look at this bottle. It has misbranded written right on the label, which is a great way to remember that misbranding is all about labeling issues, missing information, incorrect claims, or misleading details. Now let's talk about the pills. We have one blue and one red. If you've seen the matrix, you know how important it is not to mix them up. Imagine if their contents were swapped, that would be a serious problem with what's inside. That's what we call adulteration, issues with the actual composition or purity of the drug. So remember, misbranded, think of label problem. Adulterated, think of content problem. Now here I have a question for you. A pharmacist receives generic doxycycline labeled as 100 mgs, but testing reveals 200 mgs per capsule. With no indication of the discrepancy, several prescriptions are dispensed before detection. How should these capsules be classified? Adulterated, misbranded, both, or neither? And the correct answer here is C. The capsules are both adulterated and misbranded. So why are they considered adulterated? Well, the actual strength of the drug is 200 milligrams, but the label says 100 milligrams. That's a clear violation of drug dosing. And what about misbranding? In this case, the dosage listed on the label is wrong, which means patients and healthcare providers could be misled about how much of the drug they're actually getting. So therefore, this is a scenario where the drug is both adulterated and misbranded. Moving on with the next section, the Food, Drug, and Cosmetic Act of 1938. This was a huge turning point in drug regulation, and unfortunately it came after a tragic event. A sulfanilamide elixir made with a toxic solvent led to the deaths of over 100 people. This disaster pushed Congress to act, and they passed the FDCA, giving the FDA the power to review drug safety before anything could be sold. So what did this law actually change? Here are the key takeaways. Drug manufacturers now had to prove their products were safe before they hit the market. Labels had to include clear directions for use and warnings for habit-forming drugs. Regulations expanded to cover cosmetics and medical devices. Please note that the FDA does not classify soap as a cosmetic if it primarily cleanses, consists of alkali salts or fatty acids, and contains no synthetic detergents or cosmetic claims. However, if it includes synthetic detergents or claims like moisturizes skin, it is considered a cosmetic. Most FDCA violations today still involve adulteration or misbranding, just like we discussed earlier. In order to help you remember this law, think about safely applying cosmetics. Just like you wouldn't want to use unsafe makeup, the FD Cosmetic Act ensures the safety of food, drugs, cosmetics, and medical devices before they reach the public. The next law is the Durham-Humphrey Amendment, which was a major update to the FDCA, creating a clear distinction between prescription drugs, also called legend drugs, and over-the-counter, OTC drugs. This was important because some medications required medical supervision to prevent misuse. Here's what this law changed. It created two drug categories, prescription and OTC. Prescription drugs had to include a warning label stating, "Caution, federal law prohibits dispensing without a prescription." Since these drugs were prescribed under medical supervision, they didn't need detailed directions for use on the label. OTC drugs, on the other hand, had to include clear usage instructions so consumers could use them safely without a doctor's guidance. The FDA regulates OTC drugs through a monograph system, which sets rules for ingredients, dosages, and labeling. One interesting rule to remember: if an OTC drug is prescribed and dispensed as a prescription, it must follow prescription labeling standards, not OTC labeling. Another key change: oral and verbal prescriptions became legal, along with prescription refills, making it easier for patients to access their medications. This amendment made drug regulations clearer and safer for both patients and pharmacists. Here are a few fun memory tricks to help you remember the Durham-Humphrey Amendment. First, think of it as Durham drew the line, because that's exactly what this law did. It drew a clear line between prescription drugs, also called legend drugs, and over-the-counter OTC drugs. Next, picture yourself driving without a license. It's illegal. Just like you need a license to drive, you need a prescription to get certain medications. And finally, think about street signs. They provide clear directions to keep everyone safe. That's similar to how OTC drug labels must include clear instructions so consumers know exactly how to use them safely. So remember, Durham drew the line, prohibited dispensing legend drugs without a prescription, just like how you cannot drive without a driver license, and imposed regulations on over-the-counter drug labels with adequate directions, similar to street signs giving you directions. Next, let's talk about an important turning point in drug regulation, the Kefauver-Harris Amendment of 1962. This law changed the way drugs are tested, approved, and marketed, all thanks to the efforts of Senator Estes Kefauver from Tennessee and Representative Orrin Harris of Arkansas. Kefauver was a major force in exposing shady practices in the drug industry. But what really pushed this amendment forward was the thalidomide tragedy, a drug that was supposed to help with morning sickness but ended up causing devastating birth defects worldwide. This crisis made it clear that drug regulations needed a serious overhaul. So what did the Kefauver-Harris Amendment actually do? Well, it was a game changer because for the first time, drug companies had to prove that their products were both safe and effective before they could be sold. That was a big shift in the FDA's power, giving it more control over clinical trials, drug approval, and even advertising. Here are some key changes this law introduced. First, drugs now had to be backed by solid evidence showing they were both safe and effective before they hit the market. Second, drug ads had to be honest. Companies now had to disclose side effects and contraindications instead of just making big misleading claims. Third, patients in clinical trials had to give informed consent before participating, meaning they had to fully understand the risks before agreeing to take part. Fourth, good manufacturing practices became mandatory to make sure drugs met strict standards for quality, strength, and purity. Today, the FDA enforces current good manufacturing practices, CGMPs, to prevent contamination and ensure safe production. And finally, manufacturing facilities had to be inspected every 2 years to make sure they were following the rules. Not following CGMPs, that was considered adulteration. Failing to register with the FDA, that was considered misbranding. Both serious violations. This amendment completely transformed the way drugs are developed and approved, making sure that medications are safer and effective for consumers. It's one of the biggest reasons why today's drug approval process is so rigorous. And here's a memory aid to help you remember the Kefauver-Harris Amendment. Take a look at the drug bottle. You can see CGMP written on it. This reminds us that this amendment established good manufacturing practices, GMPs, to ensure drug quality, safety, and purity. An alternative memory aid that I find helpful is Kefauver, sounding like Kefective, and S of Harris reminding me of safe. So this law focuses on effectiveness and safety of the drugs. Alright, let's move on to the next law, Controlled Substances Act, or CSA for short. This law was passed as a response to the growing problem of drug abuse and the need for tighter regulation. Basically, it created a system to classify drugs based on two key factors: their potential for addiction and whether they have any legitimate medical use. Here's the gist of how it works. Drugs are divided into 5 schedules from 1 to 5. Schedule 1 drugs are considered the most dangerous. They have a high potential for abuse and no accepted medical use. A good example, heroin. On the other end of the spectrum, Schedule 5 drugs have the lowest potential for abuse and are commonly used in medicine. Things like certain cough syrups. We'll dive deeper into these schedules in the next chapter. But classifying drugs wasn't the only big change this law introduced. It also did a few other important things. First, it officially set up this drug scheduling system 1 through 5. Second, it created the Drug Enforcement Administration, DEA, to enforce these controlled substance laws. And third, it established strict rules for how controlled substances should be prescribed, dispensed, and documented, basically keeping track of who's handling these drugs and how. Now, one more key point. The Attorney General technically has the power to add, remove, or reclassify drugs within this system. But in reality, this job usually falls to the DEA, which operates under the Department of Justice. So in a nutshell, the CSA set up a framework to regulate drugs, assigned enforcement to the DEA, and gave the government the power to adjust drug classifications as needed. Next, we have the Poison Prevention Packaging Act, PPPA, to protect young children, specifically those under 5 years old, from accidentally ingesting harmful substances. The goal is simple: make sure certain household products and medications are packaged in a way that makes it really tough for kids to open while still being accessible for adults. So how does it work? Child-resistant packaging has to be designed so that at least 85% of children under 5 can't open it within a reasonable time, but at least 90% of adults can. The Consumer Product Safety Commission, CPSC, not the FDA, is responsible for enforcing these packaging rules. Therefore, if a product doesn't comply, it's actually a violation of both the PPPA, enforced by the CPSC, and the FDCA, considered misbranding, enforced by the FDA. Now, there are exemptions to the Poison Prevention Packaging Act, PPPA. Not all medications require child-resistant packaging, and there are some key reasons why certain drugs are exempt. Instead of memorizing a long list, it helps to understand the reasoning behind these exemptions. So what are the main exemptions? Patient or physician request. If a doctor or patient specifically asks for non-child resistant packaging, it can be provided. This usually happens when the risk of child exposure is low. Bulk containers and institutional use medications that come in large containers or are used in hospitals, nursing homes, or long-term care facilities, LTCFs, don't need child-resistant packaging. These are handled by professionals, so the risk to children is practically non-existent. Certain over-the-counter medications for elderly or disabled individuals, one package size, can be sold in non-child resistant packaging if it's labeled with a warning like, this package is for households without young children. This helps people who might struggle with child-resistant caps. Hormonal medications and contraceptives, drugs like birth control pills, orthotricycline, hormone replacement therapy, and medroxyprogesterone acetate are usually dispensed in blister packs or controlled doses, and they have a relatively low risk of toxicity. Emergency and fast-acting medications. Some drugs like sublingual nitroglycerin or chewable isosorbide dinitrate need to be accessible immediately during emergencies. In these cases, the priority is speed over child resistance. Low-risk or controlled dose medications. Some drugs come in forms that reduce the risk of accidental poisoning, such as effervescent tablets, aspirin, acetaminophen, erythromycin ethyl succinate granules, potassium supplements in unit dose packaging, and sodium fluoride up to 264 milligram. These are either low toxicity or designed in a way that makes overdose less likely. Medications for chronic or long-term use, drugs like anhydrous cholestyramine, cholestyramine packets, pancrelipase, and certain sucrose-based solutions don't pose a significant overdose risk, so they're exempt. Corticosteroids and anti-inflammatories, medications like prednisone less than equals 1.5 milligrams, methylprednisone less than equals 84 milligrams, and betamethasone less than equals 12.6 milligrams are typically prescribed in small doses, meaning the risk of serious harm from accidental ingestion is low. Parasitic and infectious disease treatments. Some drugs used to treat infections, such as mebendazole less than equals 600 milligrams, and erythromycin ethylsuccinate, less than equals 16G, are considered low risk because they are taken in controlled doses over a short period. Some products are designed so that the only way to access them is through a spray mechanism, like aerosols, pump sprays, or trigger-actuated sprays. These often have built-in child-resistant features or a permanently attached mechanism, which helps prevent accidental exposure. So rather than memorizing a long list of exemptions, just keep in mind that the reasoning usually comes down to low toxicity, controlled dosing, professional handling, or the need for quick access. Here's a simple trick to help you remember the Poison Prevention Packaging Act, PPPA. Just think of the pea poppy flower in this image. The word poppy sounds a lot like PPP, making it an easy mental cue. And don't forget, the PPPA is monitored by the Consumer Product Safety Commission, CPSC, to help keep children safe from accidental poisoning as written on the bottle. All right, next, let's talk about the National Drug Code, or NDC, which was mandated by Drug Listing Act of 1972. NDC is a 10-digit number that the FDA assigns to drug products in the US. It works like a unique ID, helping to identify medications. This number is broken down into three parts. First, we have the labeler code, which is the first 4 to 5 digits. This tells us who made or distributed the drug. Then comes the product code, which is the next 3 to 4 digits. This part gives details about the drug's strength, dosage form, and formulation. And finally, there's the package code, which is the last 1 to 2 digits. This specifies the package size and type. One important thing to note, the presence of an NDC does not mean the drug is FDA approved. It's mainly used for identification and tracking. Likewise, while it's encouraged to include the NDC number on labels for over-the-counter unit dose packaging and prescription medications, it's not a regulatory requirement. Now, here's an easy way to remember the order of the MEC numbers. You can see in this picture that a man, which stands for manufacturer, is holding a drug in his hand and a package is on the floor. That gives us the order from left to right. Man manufacturer code first, then the product code, and finally the packaging code. Next, we have the Orphan Drug Act, passed in 1983. Before this law was passed, pharmaceutical companies had little incentive to develop treatments for rare diseases, also known as orphan diseases, because they affect fewer than 200,000 patients in the US. With such a small patient population, companies didn't see much profit potential, so many of these diseases were left without effective treatments. That's where the Orphan Drug Act stepped in. This law provided financial and regulatory incentives to encourage drug manufacturers to focus on these rare conditions. Here's how it helped. It offered tax incentives and grant funding to support orphan drug research. It also gave companies 7 years of exclusive marketing rights once they developed an orphan drug, meaning no direct competition for that time. Thanks to these incentives, we've seen major advancements in treatments for rare diseases that might have otherwise been ignored. Next, we have the Drug Price Competition and Patent Term Restoration Act of 1984, also known as Hatch-Waxman Act. This law helps strike a balance between innovation and affordability in the pharmaceutical world. Before this act, brand name drug manufacturers had a monopoly on their products for years, making medications expensive. At the same time, developing generic alternatives was a long and costly process. Hatch-Waxman changed that by creating a clear pathway for generic drug approval while still protecting brand name drug innovation. Here's what the act did. It introduced the abbreviated New Drug Application, ANDA, allowing generic drug makers to get FDA approval by proving bioequivalence to an already approved brand name drug. They didn't have to redo full clinical trials, which sped up the process. As an incentive for competition, the first generic drug manufacturer to file an ANDA was rewarded with 180 days of market exclusivity, meaning they could be the only generic available for 6 months. The 505(b)(2) application allowed new drug approvals without duplicating safety and efficacy studies. if the reference drug had already undergone those trials. This was especially useful for new formulations like different salts, esters, or dosage forms. To compensate brand name manufacturers for the time spent in FDA review, the law granted them an extra 5 years of patent protection before generics could enter the market. The Act also created the Orange Book, a go-to resource listing all FDA-approved drugs and their generic equivalents. The FDA defines bioequivalence as having key pharmacokinetic values like area under the curve, AUC, and maximum concentration, Cmax, within a range of 80% to 125% of the reference product. And finally, to ensure transparency, generic drug labels must include statements like substituted for brand name so patients know what they're getting. Overall, the Hatch-Waxman Act made it easier and faster for generic drugs to reach the market, increasing affordability while still rewarding innovation. So here I got you another nice memory aid to remember what the Hatch-Waxman Act did. Think of a hatchling emerging from an egg. The bird represents the brand name drug, and the hatchling symbolizes the newly introduced generic drug. Just like a hatchling, generics are born after the brand name drug has already been established. The next section is Prescription Drug Marketing Act, or PDMA, of 1987, a law designed to protect the pharmaceutical supply chain from counterfeit, adulterated, or expired drugs. Before this act, drug diversion and unsafe distribution practices posed serious risks to patients. The PDMA helped tighten regulations on drug samples, re-importation, and prescription drug sales by hospitals and healthcare entities. So here's what it does. Drug wholesalers must be licensed in any state where they operate, whether they distribute drugs within a state or across state lines. Prescription drugs cannot be re-imported into the U.S. except by the original manufacturer. Patients generally can't bring foreign drugs into the U.S., but there's an exception for personal use if the supply is less than 90 days and is medically necessary. The Act also permitted the use of starter packs for initial patient treatments and regulated the sale, trade, and purchase of drug samples. So here are the drug sample regulations necessitated by this law. Selling or trading drug samples is strictly prohibited. Retail pharmacies generally can't have samples. Only hospital pharmacies and healthcare entities can receive them upon written request. Hospital pharmacies must store samples separately from regular inventory to prevent unauthorized access. And finally, a licensed practitioner must submit a written request for drug samples specifying the drug, quantity, and date. So for this act, I've got you two different memory aids. The first one is a mnemonic, where you can think of markets as an acronym: mandatory wholesaler licensing, adulteration prevention, reimportation ban, kits for starter packs, exceptions for personal use. And finally, trade and sample restrictions. And then I am more of a visual person than brute memorization, so I personally prefer this image to remember contents of the PDMA. So you can see in this image that there is a market canopy at the top. That represents the Marketing Act, a simple way to anchor the name Prescription Drug Marketing Act in your mind. Next, you see a wholesaler signing a document signifying their need to be licensed. Up in the sky, there's an airplane flying and the cargo underneath. That symbolizes the reimportation restrictions. On the table, you'll spot a sample drug and a starter pack, and finally the two capsules on the right side of image being mixed together, which is an example of an adulterated drug. So I understand that some of the components of this act might be all over the place, but if you can picture this image in your mind, remembering the key components of the PDMA is like a breeze. The Federal Anti-Drug Abuse Act of 1988 is all about keeping the workplace drug-free. It makes it illegal for employees to have controlled substances at work, and it gives employers the authority to take action to ensure a safe and compliant environment. If an employee is convicted of drug possession, they're required to notify their employer within 5 days. This law helps reinforce accountability and keeps workplaces safe for everyone. The Omnibus Budget Reconciliation Act of 1990, or OBRA 90, set important standards for pharmacists, especially when it comes to patient counseling and drug utilization reviews. Under this law, pharmacists must review prescriptions before filling them and offer counseling to Medicaid patients at no extra cost. As a matter of fact, many states have expanded these requirements to cover all patients, regardless of their insurance status, and not just Medicaid patients. Now, what does this counseling include? Pharmacists have some flexibility when it comes to counseling, but it generally covers key details like the medication's name, dosage, how to take it, precautions, possible side effects, interactions, storage, refill info, and what to do if a dose is missed. If a patient refuses counseling, the pharmacist must document that refusal by noting their name or initials on the prescription, or to document in the records. The DUR process itself is all about catching potential issues before they become problems. Pharmacists check for things like duplicate therapies, drug disease contraindications, drug interactions, incorrect dosages or durations, allergies, and even signs of abuse or misuse. Next, we have the Dietary Supplement Health and Education Act of 1994 set the rules for how dietary supplements are regulated, balancing consumer access with safety standards. Here are the key takeaways. It officially categorized dietary supplements as a type of food covering things like vitamins, minerals, herbs, amino acids, and their extracts. Unlike prescription drugs, supplements don't need FDA approval before hitting the market. Instead, it's up to manufacturers to ensure their products are safe and their claims are backed by evidence. Every supplement must have a supplement facts label listing serving size, ingredients, and key nutritional details. Companies can make claims about nutrient deficiencies, general health support, and normal body functions, but they cannot claim to diagnose, treat, cure, or prevent diseases without FDA approval. As a matter of fact, if you've ever listened to a supplement commercial on the radio, you've probably noticed that disclaimer at the end. This product is not intended to diagnose, treat, cure, or prevent any disease. That's not just a random statement. It's actually required by law. The FTC oversees supplement advertising to make sure it's truthful and not misleading. Any ingredient not marketed in the U.S. before October 15, 1994 must go through an FDA safety review before it can be sold. Manufacturers must follow good manufacturing practices to ensure quality and safety. If a supplement causes a serious adverse event after it's on the market, the manufacturer is required to report it to the FDA. So in brief, essentially put the responsibility on supplement companies to ensure their products are safe while keeping the FDA involved in post-market oversight. Next, let's talk about HIPAA, which I am sure you have all heard of, standing for the Health Insurance Portability and Accountability Act. It was created to improve health insurance portability, reduce fraud and abuse, and most importantly, protect patient health information, or PHI. It also set national standards for electronic healthcare transactions to make the system more efficient and secure. Then in 2009, the HITECH Act, Health Information Technology for Economic and Clinical Health, came along and made HIPAA even stronger. It pushed for the adoption of electronic health records, EHRs, enhanced privacy and security protections, and increased penalties for violations. Key parts of HIPAA include standardized transactions and codes. This helped simplify electronic healthcare transactions, making billing and record keeping more efficient while cutting administrative costs. National Provider Identifier, NPI. All healthcare providers, doctors, nurses, pharmacists, dentists, therapists, and even labs need an NPI to streamline billing and reduce fraud. Protecting health information, HIPAA requires safeguards to keep PHI confidential and secure. This means shredding sensitive documents, locking up medical records, and limiting access to only those who need it. Patient privacy rights. Patients have the right to access their health records, and providers must provide them within 30 days of a request. This is the federal timeframe for providing pharmacy records to patients, but some states may impose stricter regulations with shorter deadlines. With regards to the HITECH Act, it promoted electronic health record EHR adoption by offering financial incentives. It increased penalties for violations. It expanded enforcement, giving state attorneys general more power to go after HIPAA violations. It extended privacy and security rules to business associates, not just healthcare providers. If there's a breach of unsecured PHI, affected individuals must be notified as soon as possible, but no later than 60 days after discovery. If 500 or more people are affected, the Department of Health and Human Services, HHS, and the media must also be informed. For smaller breaches under 500 individuals, HHS can be notified annually within 60 days of the end of the calendar year. Next, we have HIPAA enforcement and penalties. Civil penalties can have fines up to $100 per violation, maxing out at $25,000 per year. Criminal penalties. If PHI is disclosed knowingly, fines go up to $50,000 and 1 year in jail. If PHI is used under false pretenses, penalties increase to $100,000 and 5 years in jail. If someone uses PHI for personal gain or harm, fines can be as high as $250,000 and up to 10 years in prison. So when can pharmacists share PHI? Pharmacists are allowed to disclose PHI under 3 key circumstances, often called TPO, T standing for treatment, sharing information with a doctor involved in a patient's care, P standing for payment, submitting billing information to an insurance company, O standing for healthcare operations, things like audits, quality reviews, or staff training. A pharmacy can also share patient health information or PHI without patient authorization for face-to-face communication or refill reminders. However, outside of these situations, PHI cannot be disclosed without a court order unless it's for law enforcement in cases involving serious crimes, deaths, emergencies, mandatory reporting, child abuse, where consent isn't required. At its core, HIPAA is about balancing patient privacy with necessary information sharing, making sure healthcare runs smoothly while keeping sensitive information protected. The next act is Food and Drug Administration Modernization Act of 1997, a law designed to make the FDA's regulatory process more efficient, ultimately helping patients get access to safe and effective drugs and medical devices more quickly. So what did FDAMA actually change? Here are some key points. Increased FDA accountability. This law required the FDA to develop a clear mission statement, making it easier for the public to understand the agency's responsibility. Fast-track review. One of the biggest changes was the introduction of an expedited review process for drugs aimed at treating serious or life-threatening conditions. Drug companies could use surrogate endpoints, basically early indicators that a drug might work, as long as they followed up with post-marketing studies to confirm the drug's actual benefits. Pharmacy compounding edits Section 503A, which we'll discuss in more detail in Chapter 8. Prescription labeling. You might remember the old labeling statement, caution, federal law prohibits dispensing without a prescription. Well, FDAMA replaced that mouthful with a much simpler phrase into RX only. Next, we have the pediatric studies to encourage research on how existing drugs work in children. If a company conducted FDA requested pediatric studies, they got an extra 6 months of market exclusivity before generics could hit the market. Advertising regulations. Pharmaceutical companies were given some flexibility here. They could now share peer-reviewed journal articles about off-label uses with healthcare providers under certain conditions, of course. Plus, they were allowed to provide economic data about their drugs to formulary committees, which help determine which drugs get covered by insurance plans. Here's a simple memory trick to help you remember the key components of the FDAMA. A kid is reading a newspaper, and on that newspaper you see advertisements. These represent pediatric research and advertising regulations. Now, in the background, there's an emergency vehicle speeding down a fast-track road. That's your cue for the fast-track review process. Next, an FDA scale of justice symbolizing increased FDA accountability. On one side of the scale, there's an RX symbol representing the new prescription labeling rule. On the other side, you see 503A, which stands for pharmacy compounding. So all you have to do is to remember this picture to easily recall the components of the FDAMA Act we have just discussed. Next, let's talk about the Medicare Modernization Act of 2003, or MMA for short. This law made some big changes to Medicare, with the most notable being the creation of Medicare Part D, which added prescription drug coverage for the first time, and we'll dive deeper into that in later chapters. MMA also introduced tax-free health savings accounts, or HSAs, giving people a way to save money for medical expenses while enjoying some tax benefits. And on top of that, it expanded Medicare's preventive services, making it easier for seniors to access screenings and other preventive care. Another important law is the Combat Methamphetamine Epidemic Act, a federal law that was passed on March 9, 2006 to crack down on the illegal production of methamphetamine. The key focus of this law was regulating the sale of certain over-the-counter medications that contain chemicals like ephedrine, pseudoephedrine, and phenylpropanamine, because these substances can be used to make meth. In fact, if you have seen the Breaking Bad TV series, then that was a good example. So what does this law actually do? First, it enforces purchase limits. In other words, to prevent bulk purchases for illegal use, there are strict limits on how much of these products you can buy. And these are some important numbers that you need to know for your MPJE exam. The daily limit is 3.6 grams, which is about 146 tablets if you're buying the 30 millitablet dose of pseudoephedrine. If you go for the 60 milligram mg tablets, you can only get 73 tablets a day. And for 120 mg tablets, the limit is 36 tablets per day. The monthly limit is 9 grams in a 30-day period, which translates to 366 tablets of the 30 milligram version. If you're ordering by mail or buying from a mobile vendor, the limit is 7.5 grams per month, or around 305 tablets of 30 milligram pseudoephedrine. Also, if a mobile retailer sells these products, they must be locked up so customers can't grab them off the shelf. There's also an age requirement. The age limit for most states is 18, but there are exceptions, like in Texas, for instance, where the age limit is 16. The law also enforces record-keeping and storage rules. Because these drugs are now classified as Schedule 5 controlled substances, they must be kept behind the pharmacy counter or in a locked cabinet if they're on the sales floor. They can only be sold by authorized pharmacy staff like pharmacists, pharmacy interns, or certified pharmacy technician. Every sale must go through an electronic tracking system that follows federal and state regulations, and before making a purchase, customers have to show a valid government-issued photo ID. Pharmacies selling these products have a few key responsibilities. Staff training, where employees must be trained on both federal and state regulations related to the law. Electronic sales logs, where every sale must be recorded and kept for at least 2 years. Detailed documentation, where the pharmacy must record date and time of sale, quantity sold, purchaser's name, address, and date of birth, type of ID used, ID number, and initials of the dispensing staff. There are, however, some exceptions to electronic reporting. A pharmacy or retailer can request an exemption if they don't have the required technology to track sales electronically, or if they sell less than 72 grams of ephedrine or similar compounds in a 30-day period. Every pharmacy needs to maintain a logbook of all sales for 2 years, including details like product name and quantity sold, purchaser's name and address, date and time of the transaction. However, there is one exception to logbook if a customer is buying a single convenience package with less than 60 milligram of pseudoephedrine. They don't have to be logged. So as always, I've got you a simple visual aid to help remember the key components of the Combat Methamphetamine Epidemic Act. You can see a CMEA labeled bottle sitting on a table. That's the name of the act. Next to it, there's a logbook that tracks the sale of methamphetamine precursors. The pharmacist is carefully checking the ID of a customer before completing the sale, reminding us that age limit applies to these products. Beside the bottle, you spot a 60 mg container, which refers to single-use convenience packages with less than 60 mg of pseudoephedrine that are exempt from logbook requirements. Finally, on the table background, you see a triangle with the numbers 3, 6, and 9 on its sides. This represents the purchase limits under the CMEA. So number 3 and 6 refer to 3.6 grams daily limit, and then number 9 refers to 9 grams per month purchasing limit. So again, I am a visual person and I prefer to picture these images in my head to recall the key components of each act. But like I said before, if you have alternative modes of recalling these details, then by all means, as long as it helps you recall during the exam, that's all that matters. Next, we have regulations for online pharmacies. Back in 1999, VIPS program, which stands for Verified Internet Pharmacy Practice Sites, was created to address concerns about the safety of online pharmacies. At the time, the internet was exploding in popularity and people started buying medications online, sometimes from unreliable or even illegal sources. VIPS was introduced to accredit legitimate online pharmacies, ensuring they followed proper safety standards. But that wasn't enough. As online drug sales grew, so did the risk of illegal sales of controlled substances, which led to the passing of the Ryan-Haight Online Pharmacy Consumer Protection Act in 2008. This law put stricter rules in place to prevent the illegal sale of prescription drugs online, especially controlled substances. Key rules under the Ryan-Haight Act include valid prescription requirement, where a controlled substance can't be dispensed unless it's prescribed for a legitimate medical purpose by a healthcare provider. The provider must have evaluated the patient at least once, either in person or through a telemedicine visit, before writing the prescription. Online pharmacies must have a special registration to dispense controlled substances. They also have to follow state laws regarding how these medications are delivered. Before starting online pharmacy operations, they must register with the DEA at least 30 days in advance. If an online pharmacy wants to operate in a specific state, it must notify both the DEA and that state's Board of Pharmacy at least 30 days before doing business there. If an online pharmacy dispenses at least 100 prescriptions or 5,000 dosage units of controlled substances in a month, it must submit a detailed report to the DEA every month. This report includes the quantity and National Drug Code NDC of each controlled substance dispensed. Online-only prescriptions are not accepted. Prescribers cannot issue a controlled substance prescription based solely on an online survey or questionnaire. There must be a real medical evaluation behind it. Now, why does all these tight regulations matter? These rules exist to prevent abuse, addiction, and illegal sales while still allowing legitimate patients to get the medications they need. The VIPS program ensures that licensed online pharmacies meet safety standards, and the Ryan Act keeps controlled substances from being misused. Together, these regulations help strike a balance between convenience and safety with online purchasing of medication. Then again, here's another great way to visualize and remember the key points of the Ryan-Haight Act and VIPS regulations. You can see Ryan sitting at a computer, and next to him There's a vaporizer symbolizing Ryan Act and the VIPPS program that ensures online pharmacies and controlled substance purchases meet safety standards. And then on the table you see a big number, 30. That number reminds you of the 30-day notification rule, the requirement for online pharmacies to notify the DEA at least 30 days before they start dispensing controlled substances, as well as monthly reporting period if dispensing more than certain amount of controlled substances in a month. All right, let's move on to the Affordable Care Act, better known as Obamacare. The goal of this law was pretty simple: make healthcare more accessible and affordable for Americans. It tackled issues like high healthcare costs and unfair insurance practices, especially denying coverage for pre-existing conditions. It also expanded preventive care and set up state-run insurance marketplaces where people could shop for coverage. The key provisions of the ICA, the individual mandate, which is now gone, by the way. Originally, the law required everyone to have health insurance or pay a penalty, but that penalty was effectively removed in 2019 under the Tax Cuts and Jobs Act of 2017. The ACA expanded Medicaid eligibility to help more low-income individuals get coverage. Insurance plans must cover preventive care like vaccines, screenings, and checkups at no extra cost to the patient. Closing the Medicare Part D donut hole. The ACA reduced prescription drug costs for Medicare enrollees by closing the coverage gap known as the donut hole, contraceptive coverage. Most private health insurance plans must fully cover FDA-approved birth control methods for women, including emergency contraception like Plan B, levonorgestrel, and elaprestol acetate. Note, ELA requires a prescription and is recommended if more than 72 hours have passed since unprotected sex. If you're under 26, you can stay on your parents' health insurance plan, a major win for young adults. Insurance companies can't deny coverage or charge higher premiums just because someone has a pre-existing medical condition. The Women's Preventive Services Guidelines introduced in 2012. This ensures coverage for key women's health services without cost sharing, including well-woman visits, screenings for gestational diabetes, counseling for STIs and HIV, and contraceptive counseling. Now, let's visualize these provisions in a way that makes them easy to remember. Picture a 26-year-old Obama sitting at a table. He's still covered by his parents' health insurance, thanks to the ACA. In one hand, he's holding a donut, symbolizing how the ACA closed the Medicare Part D donut hole and reduced prescription drug costs. On the table, he has just $1 bill, yet somehow it's enough to qualify for Medicaid. That represents the Medicaid expansion that helps more low-income individuals get coverage. Also on the table, we see items representing the Women's Preventive Services Guidelines, pills for breast and cervical cancer screenings, anxiety screenings, and urinary incontinence screenings. A knife symbolizing screening for intimate partner and domestic violence. A milk bottle representing breastfeeding support. A box of donuts, reminding us of obesity prevention, diabetes screening, and well-woman visits. A reproductive shield representing contraception, STIs, HIV, counseling, and protection for reproductive health. The Drug Quality and Security Act, DQSA, was passed in response to a major public health crisis, the 2012 fungal meningitis outbreak linked to contaminated compounded drugs. This tragedy raised serious concerns about the safety of drug compounding, leading to the creation of new standards for compounding pharmacies and a national system for tracking and tracing prescription drugs across the supply chain. Let's break down the key provisions of this law. 1. Drug Supply Chain Security Act. In November 2013, Congress passed the Drug Supply Chain Security Act, DSHEA, as part of the DQSA. The goal, prevent counterfeit drugs from entering the market by tightening security measures across the drug supply chain. Who's in the game? Only authorized trading partners can distribute prescription drugs. The law requires maintaining 6 years of transaction data, which includes transaction information that includes basic details about the drug, transaction history, including a record of where the drug has been, transaction statement with declaration from the seller confirming compliance, and verification requirements. Next, we have the FDA oversight for large-scale compounding under Section 503B. Before this law, compounding pharmacies operated without clear federal oversight. The DQSA changed that by creating a voluntary FDA registration system for outsourcing facilities under Section 503B. Now, what's the benefit of 503B registration? It allows these facilities to produce larger batches of compounded drugs without individual prescriptions, but under stricter quality control standards. 503B drugs can qualify for exemptions from FDA approval and certain labeling requirements if they meet specific conditions. Here's another great memory aid to help connect DQSA to 503B outsourcing facilities. You can see a bee buzzing around, really interested in Dairy Queen DQ products. Well, DQ sounds like DQSA, and the bee represents 503B. So whenever you think of DQSA, just picture that bee at Dairy Queen and you'll instantly remember the link to 503B outsourcing facilities. All right then, that was a quick overview of the Compounding Quality Act, but don't worry, we'll dive deeper into compounding requirements later in Chapter 8. Now, let me ask you a question. Which law outlines 503A compounding? And the answer is FDA Modernization Act, like we discussed earlier in this video and summarized with this memory aid. So a final summary slide reviewing 2 important parts of U.S. drug compounding laws. Section 503A, which came out of the 1997 FDA Modernization Act, lays out the rules for traditional compounding done in state licensed pharmacies, federal facilities, or by licensed physicians. If they meet certain conditions, these compounders get exemptions from 3 big requirements under the Federal Food, Drug, and Cosmetic Act. They don't need to go through the full new drug approval process like mass-produced drugs. They're exempt from labeling requirements that mandate detailed directions for use. They don't have to follow current good manufacturing practices, CGMPs, which are strict regulations for large-scale drug production. Instead, they follow USP 7997, which, as we will discuss in the next video, has a set of standards for preparing sterile medications in pharmacies. On the other hand, there is Section 503B, which was introduced later under the 2013 Drug Quality and Security Act, DQSA. This section applies to outsourcing facilities, basically larger scale compounding operations that function more like manufacturers but don't make fully FDA approved drugs. If they meet the requirements, they're exempt from new drug approval requirements. So like 503A compounders, they don't need full FDA approval. Labeling requirements for directions of use. Drug supply chain security requirements, which track and trace prescription drugs to prevent counterfeiting. However, unlike 503A pharmacies, outsourcing facilities must still follow CGMP requirements to ensure a higher standard of safety and quality. So in short, 503A covers traditional pharmacies and physicians with more flexibility, while 503B applies to outsourcing facilities that operate on a larger scale but with stricter regulations, including CGMP requirements and FDA inspections. Likewise, a facility that chooses to remain registered with the FDA as a 503B outsourcing facility must re-register annually. Alright then, that wraps up the first part of our MPJE lecture series. Just a quick reminder, this lecture follows the outline of our MPJE books, which you can find on Amazon. I also included the link in the description of this video. Thanks so much for listening, and we'll see you in the next video shortly.